Hi friends, welcome back to Zen with Shifana. So, STEMI patient comes to ER, and what four classes of drugs do you give in the first 30 minutes? We have dual antiplatelet therapy, anticoagulants, fibrinolytics, and secondary prevention. Let's break down this entire mind map in just few minutes. Let's go. So first, as I said, antiplatelet therapy or DAPT. DAPT means dual antiplatelet therapy. So the goal will be to stop the platelets from clumping together. In that, the first drug would be aspirin, a COX-1 inhibitor. So it acts by inhibiting the COX-1, which decreases the thromboxane A2 and prevents the platelet aggregation. The dose will be given as a loading dose of 162 to 325 mg and it should be chewed for the faster action. Then the maintenance dose would be 81 mg daily. So its side effects would be gastric bleeding, so should be careful in patient with ulcers. Then second drugs comes the P2Y12 inhibitors, that is ADP receptor antagonist. They act by blocking the ADP receptor on the platelets, so platelet cannot be activated. For example, Prasugrel, Ticagrelor, and Clopidogrel. So in STEMI with PCI plant patients, the Prasugrel will be given 60 mg as loading dose and Ticagrelor will be 180 mg as loading dose are preferred. Then the maintenance dose will be Ticagrelor 90 mg twice daily and Clopidogrel 75 mg and daily. Then what will be the side effects? Of course, it's bleeding and dyspnea, and especially the Ticagrelor can cause shortness of breath. Then comes the injectables anticoagulants. These are injectable drugs to keep a blood from clotting further. For example, unfractioned heparin, that is UFH, it acts by binding to antithrombin 3, that is AT3, which increases the inactivation of factor 10A and factor 2A thrombin. So dose would be IV bolus with PCI and with fibrinolysis given bolus plus infusion. And risk would be hemorrhage and HIT, that is heparin induced thrombocytopenia. So we should watch the platelets. Next comes the Enoxaparin, that is a low molecular weight heparin. It has high affinity for factor 10A, so it mainly inactivates the 10A factor. Dose IV bolus and followed by subcutaneous injection every 12 hours. So it's a weight based. Then advantages will be lower risk of HIT compared to UFH. Then comes the reperfusion adjuncts, also called clot busters. Use these only if PCI cannot be done within 120 minutes. Those are tissue plasminogen activators, that are tPA. It acts by converting plasminogen to plasmin, then to plasmin degrades the fibrin and break down the clot. Example, tensiplase, that is TNK-tPA, and retiplase, altiplase, etc. The key point over here is time is muscle. Your door to needle it should be less than 30 minutes. And here's the critical warning. Hemorrhagic stroke is a major risk, so checking BP before giving is very crucial. Then comes the secondary prevention and workload management. That is, the clot is gone. Now we protect the heart for long term. That is secondary prevention. First would be high intensity statin. Example, atorvastatin, rosuvastatin, which we have already seen about this in the previous video. So check it out for that. The link will be in the description and comment. And next comes the beta blockers and ACEI inhibitors. Same, we have already seen this in the antihypertensive drugs. This also have given the link in the description, so please do check it. So for the exams, we'll go for a rapid recap. That is DAPT, aspirin plus ticagrelor or prasugrel, turn off the platelets. Then comes the anticoagulant, heparin or enoxaparin to thinning the blood. Fibrinolytics, that is tPA, that bursts the clot, but high bleeding will be risk. Then comes the secondary prevention, high intensity statin plus beta blocker plus ACEI that prevents the next MI. Here comes the mnemonic ABFS, Anti-Platelet, blood thinner, Fibrinolytics, secondary prevention. And that's it, the complete STEMI drug guide. Um, if you want PDF of this, comment below. I'll send you the PDF. Then you will be the star in your clinical rounds. If this helped, click a like and subscribe to Zen with Shifana for more clinical pharmacy in English. Comment below, should I do non-STEMI next? Bye guys.